Hello and welcome to another edition of the Osteopathic Lyceum podcast. I'm going to reiterate some things that I've said before, partially in relation to a conversation I've been having with a graduate of the school. I'm going to attempt to have a different part of this conversation with the graduate so that they can express some of the things that they've been learning post-graduation on their own in practice, and how the manner in which we have organized the program here has allowed for them to keep doing that learning. Now, something that I want to say before I do any of this is that almost all practitioners, once they've graduated a program, you could call most programs essentially entry to practice, or you can say that they're going to create a competent graduate. They're not necessarily going to create an expert. They're going to create somebody who can do whatever job they're trying to do at the base level, and then throughout a career, you're going to get better. And a lot of the phenomenon that I try to leverage in how the program here at the Osteopathic Lyceum is built is to do the things that somebody moving from novice to expert would do anyways, but try to do that within the educational institution so that we can leverage the positive effects of error creation, or of error commission is probably a better term. So the challenge with any profession, especially when somebody would be attempting to work at the expert level, is that there isn't one way to do something. So there's old sayings that many people would have come across, right? There's more than one way to skin a cat. There's multiple ways to do something. There's different sayings, and obviously they're not all popping to the top of my head, which is whatever. One of the things about human beings, especially when you're involved in healthcare, is that they're the same enough that they're classifiable as humans, but they're different enough to be told apart, or to be seen as separate, or identified as separate. Something you'll hear me talk about from time to time is the concept of a paradoxical responder. So I do know some people who will take melatonin and they get wired. So they take melatonin, which should help you go to sleep, but they wake up more. The reality with some medications is that you have a dosing curve. So there's a standardized dose to body weight ratio that you would find in a lot of things. So you would apply at that level, and then you would go up just in case you didn't have enough or it didn't have the desired effect. So you have to know those things, that there is variation between individuals. And you can see this in pharmacology, you can see it in surgery. So within surgical procedures, there's enough normal variation in anatomy that the surgeon's expertise is the ability to identify the variance in structure. So there's not one cut that you make, or one place to cut, or one landmark to cut in relation to, and then that's all you ever have to do blindly. You have to alter based on what you're finding as you cut a human being open. So it would be one of the challenges with having fully automated surgeries, is that depending on the method utilized to observe the patient, whatever piece of software that would be running it may not be able to properly identify the variance and might cut through a structure that it shouldn't cut through. So you can have robot-assisted surgeries and AI-assisted surgeries, but the human surgeon still has to be the one making the judgment. Do I continue to cut here, or do I have to change how I'm cutting? Things like that. So the anatomy is variable enough. The thing with osteopathy, and the thing that you'll hear me talk about a lot, is that the environment of observation is outside the patient. So there's a lot of stuff that's happening inside in relation to what we do that we can't properly observe. So we work on motion. Even though we work on something as identifiable as relatively gross motion or relatively large motion, people are different in how they respond to what we do. So if somebody has a complaint, let's just say they have a neck complaint, and you assess everybody with a neck complaint that says the same thing. Let's just say I have pain at the bottom of the right side of my neck. Everybody who comes in that says they have pain at the bottom right side of their neck, or at the bottom of their neck on the right, however I initially phrased it, when you examine them, when you check motion, it won't all be exactly the same. First of all, they're just going to be different dimensions, period. They're going to have different general soft tissue tone. They're going to have different general ranges. Their bones will be bigger. Their bones will be smaller. There's going to be all this variance. But then there's the things that are, say, more neurologically controlled, more on the motor side especially. And then also the interpretation for that particular individual based on how you interact with them, how you talk to them, how you manually move them, how you ask them to actively move themselves, things of that nature. So there's all this variance in how they're going to respond. So osteopathy as a profession has the general concept at the start of the profession that you should not hurt the patient. Right, so you look at E. Tucker, and I think E. Tucker's writing was in 1917, but this stuff is there before. You have to secure relaxation. Don't hurt the patient, don't hurt the patient, don't hurt the patient. So E. Tucker, at the beginning of his book, Osteopathic Technique, 5 principles of osteopathy. Sorry, 5, not 5. I did this, and for those who can't see this or are only listening, I put up 4 fingers and said 5, but really I should have put up the Booker T, 5 times, 5 times, 5 times. But the 5 principles of osteopathy, according to E. Tucker in 1917, don't hurt the patient, don't hurt the patient, don't hurt the patient, don't hurt the patient, don't hurt the patient. That morphs into, across time, the barrier concept. So the barrier concept is there in osteopathy where it is not necessarily there in other hands-on professions. Other hands-on professions will use similar movements to osteopathy, but as a profession, osteopathy is primed to avoid protective responses in the patient, aka don't hurt the patient, but do so through the filter in words of the barrier concept, whether it be the direct barrier or the restricted barrier or the indirect barrier or the barrier of ease or the barrier of freedom. There are decision points that are provided through those words that exist in osteopathy as a profession that are not central to other professions. Other practitioners in other professions will not hurt the patient, but osteopathy as a profession says don't do it. I put forth the heuristic of don't make them say ouch, which really means don't interact with them in a way that gives them reason to protect themselves. So you can't move too fast, but you also can't move too slow. How do you know what's too fast? Well, if it's too fast, they jump, they wince, they pull away. If it's too slow, they tighten up because they're uncomfortable with how you're moving them. All of that points to the general variance. So it's a bunch of different examples of general variance between people. Because of that general variance, you can't teach the one way. So you can't teach the one way to deal with the bottom right side of the neck. You have to teach in order to identify what is not moving in that particular individual. So you have to teach how to assess. There is not one way to assess. You can teach people to build a standard assessment protocol, but when that standard assessment protocol isn't providing the results that the practitioner would need to interface with the person who's presenting, they need to be able to adjust it and make a new one. Most practitioners will do this implicitly. They'll change what they're doing implicitly across a career, but they may not do it at any given point in their career. It may take them a long time and a lot of mistakes that they can't necessarily tell that they're making. So, what do you do about that in order to teach assessment skills such that a student who will become a practitioner can assess the person appropriately? Well, you have to teach them how to test all things in the body in as many ways as possible from scratch. So we utilize what's called a discovery followed by guided learning process. So the discovery learning is the student's going to experiment and try things. What that looks like is you give them a concept. Say, I want you to consider relational motion, right? One thing moves, one thing stays still in relation to it. I want you to try to get cervical rotation without moving the head or neck. Okay, well, how do you do that? Really, the only way to do it is to have a still head and neck and move the torso underneath the still head and neck. But you give them the opportunity to come to that solution on their own. Once they have come to that solution, or maybe not come to that solution, you display it, you demonstrate it. Okay, so fundamentally in seated, okay, now you've figured out that you move the torso, right? So you keep the head and neck still and you rotate the torso, and that's cervical rotation with a still head moving torso. And that's how you utilize a discovery approach to get through the heuristic or the abstract concept or the far transfer framework of relational motion, at least with one example of a still head and neck and moving torso for cervical rotation. Then you say, I want you to do that in all different positions. So now the discovery learning process is, in supine, can you recreate the same thing? In prone, can you recreate the same thing? In lateral, can you recreate the same thing? And the answer is yes. Now you know the general framework, but you're getting more examples of how you use relational motion as a heuristic, as an abstract problem-solving framework, or as a far transfer framework. All of those are pointing to the same phenomenon. Something that is always there in all situations, but the details will vary. So we can call that a far transfer framework or a far transfer concept, but I can use interchangeable terms that point to the same phenomenon. While you're trying that, while you're discovering that abstract framework with the details of still head and neck and moving torso in order to create cervical rotation or relative cervical rotation, you're also experiencing the hands-on phenomenon of doing that to different people and how to interact with those details. So we create the skill set from scratch in order to generate assessment in novel circumstances by providing a framework, providing a novel problem, and asking for solutions, then also demonstrating solutions, then taking that farther, then practicing that on different people. So you're instantiating the far transfer framework of create something from scratch, work on a skill, notice the difference between people, and then you're consistently interfacing with that phenomenon of the more far transfer learning style and problem solving style because people are different. So we get people through the whole body in that fashion, creating tests, both active and passive, from scratch. Then we ask them to edit that process and create a framework whereby they can very quickly identify where in the body they would need to investigate more. And then we get them through, from scratch, all the smaller areas in the body. How would you actively get the person to do this? How would you passively get the person to do this? So medial border of the scapula, lateral border of the scapula, how do you investigate that more? So we take you through that from scratch in a discovery followed by guided learning process. Then we ask you to edit and have your standardized approach. You make your own standardized approach to assessment that you're going to do on most people, such that when that doesn't work, all you have to do is reach for the things that you've already edited out or thrown out. And you do that from the abstract problem-solving framework, from the heuristic, from the far transfer paradigm, for far transfer framework, so that when encountering a novel situation, the student, whether they know it or not, has learned how to figure out what to do for an individual in any given circumstance that is presented. Because you can't possibly provide exhaustive demonstration for every situation that they're going to encounter and the variance between people, you can't possibly teach step by step how to do things and expect it to work based on cognitive load and memory demands. They're not going to remember that many things. If you work the problem-solving framework, the far transfer paradigm, the far transfer framework, and you do it by explicitly naming or describing some way for them to choose between these things and work between these things, which I call a heuristic or a heuristic framework. So the table makes stable, less table means I need to make the patient stable, the space between us is unstable, and how do I choose the position? Well, I want the anatomy to be exposed, free to move the planar planes required, and preferably visible, right? So we've got a bunch of decision points like that. All the heuristics are decision-making points. They are problem-solving frameworks, and that means that they are a far transfer paradigm. So if we lean into that and teach that way, and we lean in on the discovery followed by guided learning framework, then what we're doing is we're really teaching the student how to figure it out on their own at all times. There will be times when I provide demonstrations. So if you want to go and look at the YouTube channel, you will see some demonstrations where I do the exact same thing to multiple people. And you can immediately see that although it's the same move or the same technique, that there are very visible and very obvious differences between how it has to be done. Partially because of the size difference between myself and the patient, and also just the differences in these patients. So it's the same move, but it's obviously different when you look at it. So at all times, whether the students take this on or not, they're seeing the problem-solving approach every time a demonstration is provided. Every time they're given the chance to generate their own solution first, they're going through the process of generating your own solution first. And they're also learning which things work better and which things don't work as well. Which things work sometimes, which things work other times. It's always happening. And the reason it's always happening is because it's setting them up to not to only know, but to predominantly know that they have to figure things out on their own all the time. They clearly receive guided demonstration and guided teaching, but it's after the discovery learning. The discovery learning, the heuristic-based framework, which is pointing at a far transfer paradigm, is built in order to help the student when they go out on their own and there's no supervision. They will initially feel like they don't know what to do, but that's just because they feel like novices. Their entire educational experience at the Osteopathic Lyceum is the problem-solving experience that allows them to build supervised technical skills and get refinement because they're committing errors in a feedback-rich environment. So an error will be committed, it will be seen, it will be corrected, but the feedback will be about, this is what you do this time, right? But really what you need to be paying attention to is how that patient responds. Does that patient pull back? Okay, well, that was too fast. Why? They grimaced. It was too fast. Why? They made a noise, an abrupt response to an abrupt movement. You're moving too slow. Why? They're tight and won't relax, right? So they get this feedback chronically such that they're always doing the thing, the targeted thing that they will do, and the details vary. So this is sort of the preamble to something that will come later in a discussion with one of the graduates about what they're experiencing and the discussions that they've had with me post-graduation as they're working. All of this stuff is built on purpose. So if you go and listen to previous podcast episodes, if you go and you look at demonstrations that are available on the YouTube channel, this is always there. These concepts are always there. They're always being demonstrated, and they're usually always being explicitly said. So if I say any of my heuristics, I'm explicitly showing you this is what it is. This is one example of how it looks in practice. You extrapolate that out over a full educational program, and the students are well prepared to go out and do it on their own. Even if they don't explicitly think that way, it's all they know. And again, when I say it's all they know, it's an odd way to say it. It's the way that they know, or rather, hold on. What they know is a problem-solving framework that will allow them to functionally get into and do things that they need to do. So hopefully that made sense. Hopefully you've listened this far. Thank you for doing that. We'll talk again soon. And in the future, we'll be speaking with one of the grads about this concept as well. So just remember, if you're watching the demonstrations, you're seeing all of this all the time.